What if I told you that we could lose half your kidney function without knowing a thing? No pain, no warning signs, just completely normal. Hello, I'm Dr. Munjal Shah and I'm joined with Dr. Rahul Deshpande, who's a nephrologist, and we are here to discuss about a silent killer, chronic kidney disease, an underdiagnosed condition and which depends a lot on the lab reports that show more about the disease. Dr. Deshpande, welcome.
Yeah, thank you, Dr. Munjal. So basically, what you said, the opening line of yours, that the chronic kidney disease has the presentation of being completely asymptomatic, but at the same time, the lab tells us the completely different story.
Hello. So, Dr. Deshpande, let's start with one of the most commonly ordered tests, creatinine. I've heard many a times patients as well as doctors talking about creatinine as the ultimate test for kidney function. Is that true?
So here the mistake happens that only creatinine cannot be relied upon, because you have to understand that creatinine generation depends on many factors, like if you can say the muscle mass of the patient, the age of the patient, the gender. So these really make difference as far as creatinine production is concerned. So this taken into consideration, only creatinine cannot be relied upon. For example, two people can have a same creatinine level, but still their kidney functions can be different. So,
which is a bit counterintuitive, isn't it? We are used to seeing lab reports as normal or abnormal, right?
Yeah. So let us take one example. Some old person with a very low muscle mass and having a creatinine which is near normal of the value, but still that person can have a very low kidney function. So that's where comes in picture the test that is known as EGFR. EGFR means estimated glomerular filtration rate. Now, what is estimated glomerular filtration rate? EGFR is nothing but a formula driven value where we put three variables, that is age, the sex, and the third thing is creatinine value. So as you grow old, you tend to have a lesser GFR as compared to the younger age people, even if your creatinine value can be absolutely same. That's why EGFR comes in picture over here.
So we understand that EGFR is one of the important parameters, but then how does that help you in your clinical decisions?
Yeah. Okay. So according to EGFR, usually we stage the patients as per the CKD staging, starting from stage 1 to stage 5. Stage 5 being the severe most. So almost all decision of managing a CKD patient, in way of changing the medications, when to do a follow-up, and also to prognosticate the patient. All these crucial decisions, we rely upon the EGFR and staging of the CKD. So staging is what we decide as per the EGFR levels.
So since EGFR is such an important parameter and it is used in prognostication, that is calling the patient again to decide the dosage. So therefore the parameter on which EGFR is dependent upon, which is creatinine, is obviously extremely important. And since the formula depends on creatinine value, the creatinine should also be in a standardized manner, right?
Definitely.
Great. Great. So this reminds me of a case I recently saw. A 52-year-old man had absolutely no symptoms, came for a routine checkup. His creatinine was about 1.6, and when we calculated his EGFR, it turned out to be 51.5. So that puts him onto stage 3 CKD, and yet he was absolutely normal.
Yeah, that is what usually we face on a daily basis. So what happens is kidney has a tremendous reserve. You have a tremendous nephron mass. So before even a slightest rise in creatinine, you have to lose significant amount of nephrons with whatever insult. Means in a diabetic patient, it can be a diabetes. So you have to lose significant amount of nephrons for a creatinine to rise first. And for a patient to become symptomatic, it is even more time required for patient to become a symptomatic once the creatinine reaches to a maybe CKD stage 4 or stage 5 level.
And then there is another fascinating scenario which we got in our lab. So we have a few health packages, and one of them was availed by a 45-year-old female who was a diabetic. Her creatinine came as zero point 0.9, which is in the normal range, exactly in the normal range. But in our package, we had microalbumin creatinine ratio, and for this particular patient, the microalbumin creatinine ratio was 150. So, what do you have to say about that?
Yeah, that is exactly how the early diabetic kidney disease patient presents. So basically, diabetic kidney disease is a spectrum. So it starts with microalbuminuria and then ends up in reduction in GFR, or what you call as a rise in creatinine. So this is the exactly how diabetic kidney disease progresses.
So in short, detecting only a rise in creatinine or testing for only creatinine is only a half story. We should actually be testing something more also, which is microalbumin creatinine ratio.
Definitely. Rather, I will say once the patient reaches to us after the creatinine rise, then there is very less that we can do. Rather, if the patient reaches to us with a microalbuminuria stage, then not just it can be reduced or the progression can be halted of the diabetic kidney disease, or rather, I will say it can be completely reversed or so if it is too early, by taking good care of diabetes and by adding some drugs like what we call in technical terms, that is angiotensin converting enzyme inhibitors or ACE inhibitors, ARBs, that is angiotensin receptor blockers, or the newer SGLT2 inhibitors. So that is the time that one should be seeing the nephrologist.
So from this we understand that testing for kidney disease doesn't just involve creatinine, right? The blood test of creatinine. It also involves a urine test, which is microalbumin creatinine ratio, right? But we also know that kidney testing is not just about filtering the blood of creatinine. There are many other functions that our kidney does, right?
Yeah. So first we have to know that the kidney function is not just an excretory function. It has an endocrinal function, means it secretes a hormone called as erythropoietin, which is required for a hemoglobin maintenance. It also forms the active form of vitamin D. So ultimately the bone health and calcium homeostasis is also maintained by the kidneys. So it is not just creatinine, it is not just the urine test, but we have to monitor many other parameters, just like we usually ask repeated tests of hemoglobin levels. We also ask for a calcium, phosphorus, and a PTH levels. We also ask for a bicarbonate levels in the blood. We also ask for electrolyte levels of the patient. So these all are to be monitored regularly in any CKD patient. Basically, what I will say ki it is not just a disease which is restricted to the excretory activity or to the kidneys. It has a systemic implications also.
And therefore we have a big profile, right, for kidney usually as an RFT profile, in which we do all these tests together.
Exactly.
So from these discussions, what we understand is it's all a number game, right? So we need creatinine, we need microalbumin creatinine ratio to understand how the kidney is functioning. But Dr. Deshpande, as far as your clinical practice is concerned, how accurate should the lab be when giving you these numbers? We often classify them as normal or abnormal, but then how important is that exact number for you?
Yeah. So being a nephrologist, numbers are very important for us. So accuracy of lab is very much we depend upon. So basically, as we discussed before, the staging and all decision making about the medicines and follow-ups and everything depends on the lab numbers. So accuracy is definitely important as far as monitoring the chronic kidney disease patients are concerned.
So which is why most of the labs actually follow the quality protocols like those that are outlined in NABL and NABH protocols, right? So they ensure a good amount of standardization in the test and ensure a little bit of accuracy also, a good amount of accuracy also. However, even with all this accuracy and quality measures taken by the lab, there is still some fluctuation from the patient side also, right? Like for example, sometimes a patient, when they come in the morning to get themselves tested, they wouldn't have drank any amount of water, and we usually try to maintain some standardization in the patient's condition by telling them that don't eat food, that is, they come in fasting. So how much does that as well as the weather come in picture with respect to the fluctuations of the patient, of the results?
Yeah, so this is a good point, because as you said, some fluctuations are going to happen because of all the variable factors which are not constant. So the fluctuations are not important. There can be ups and there can be downs. What is important is a trend. So we more rely on a trend rather than a single value, and that is what we are worried about. If the trend is unusually fast rising, then only we are worried about the thing. Otherwise, some fluctuations are acceptable.
Right. So, in conclusion, we are understanding that chronic kidney disease, that is CKD, is a silent killer. And routinely, because patient would go for some routine test, that will be able to diagnose CKD even before the symptoms develop.
Yes, and if diagnosed early, it can be managed better, for sure.
Thank you so much.
Thank you.